So I'm Tasso, for those of you who don't know me. I'm one of the pediatric EM attendings, and I'll be talking about pediatric neurologic emergencies today. I want this to be, I don't want me to just talk the whole time. I want it to be pretty interactive. So I'm going to be asking you guys a lot of questions. I don't know if Jasmine, you want to help me out. If no one talks, pick him out since I can't see who's on.
Not a problem.
So some of the goals is to review the scope of common and serious non-traumatic neurologic emergencies, understand the etiologies and the inciting events, recall subtle history and physical exam findings, outline our workup in the emergency department, and discuss immediate and in-outpatient treatment. So what is the definition, right? It's an acute neurologic condition which may lead to death or permanent disability if not recognized or treated. And that's really what we in the emergency room are doing, right? We're not worrying about the non-life threatening emergencies that can be pretty much could have been seen in clinic. We want to make sure that we catch all the pathologies that, if untreated or sent home, patients can have deterioration, death, and all that bad stuff. So, on a quick assessment, right, timeline of the symptom evolution, that is critical. You want to take a really good history and look for clues to point to the category of the disease process, right? A good neuro exam, you get comfortable with a neuro exam, it really should not take more than 1 to 2 minutes to do a complete neurologic exam, right? And it can help, it can localize. And GCS, right? So kids are not, they're not like little adults, right? Even though sometimes we say that I'm comfortable with kids, very not comfortable with adults. So depending on the age, we may not be able to go head to toe like adults. You want to start with initial observation. This is key in the pediatric population. Watch how they interact, watch how they play, or if they're not playing, they're not interacting. Look at their face. Is there any droop? Are there any dysmorphic features or skin findings that you can see? And we need to kind of bring them part of into part of our exam, right? We're gonna have to use whatever we can, use some toys, use some objects, right? Look how they track. You can't just sit there telling them, a 2-year-old, follow my finger. You want to help them with that. Motor, are they using all their extremities equally, or are they favoring one side over the other? Do you see any discrepancy in the muscle, right? Is there muscle atrophy? Sensory, little kids are not going to understand if you tell them, do you feel this? Is it cold? Is it hot? Now, once they start getting a little older, then you can treat them as an adult, as an exam that you would do on an adult. Tone, right? Are they sitting there with their hips abducted? That would suggest some hypotonia. Are they arching their back? That would suggest hypertonia. So as you can see, without even you don't even have to touch a child to understand a lot of what's going on. And our GCS, it is different in a young child than in an older child or an adult, right? Most of us are, you see my mouse?
Yep.
Most of us are comfortable with this, right? But in an infant, you're not going to use this, right? They're not oriented and appropriate. You're going to use this scale. And I'm sure now with all these apps, and it's very simple, but if you can memorize this, memorize that. Now, PCARN. I know people understand what PCARN is for, right? We say PCARN negative, PCARN positive, but who can go into details on what exactly PCARN looked at? Nick, I'm going to pick on you because for some reason, you're the one that's popping up on my single video feed.
So I think PCARN only looked at a few symptoms that and age as risk factors for traumatic brain injury, and it's overly sensitive but not specific.
Okay. Now, right, they looked at a bunch of signs and symptoms until they decided to pick those few, right? And they saw which ones were the most sensitive. But when someone says PCAR negative, what does that mean? Does that mean that this patient has no injuries at all? What were they looking at specifically?
They're looking at the
Anyone can
utility of
chime in.
CT.
Right. They wanted to decrease the use of CT. But when they say, right, it is a low likelihood of what if you're PCAR negative? Is it a low likelihood of any brain injury or is it something specific? Like I said, anyone can chime in.
Jasmine is giving the answer of CTBI.
Oh, it's on the chat. Yeah. So they looked at, right, clinically important traumatic brain injury, meaning that if you scan, if a 2-year-old comes in with a head injury and they look well, they're PCON, they do not meet PCON criteria to scan. It doesn't mean that if you were to scan that child, you would find nothing. It just means that even if you were to scan, the likelihood of that patient having a clinically important traumatic brain injury is low. That's all it's saying. It's not saying that every patient that's PCAR negative has no findings. So that's something we need to understand. And when you dive deep into the study, you realize that's what they're looking for. Now, what is considered a clinically important traumatic brain injury? What are some of the criteria that they use? Does anyone know? Nobody.
I think we're talking about like clinical signs that that would make it PCARN positive. Is that what you're asking for?
Yeah.
So like altered mental state. I'm looking at it. Altered mental state.
No, so not what were the criteria that they used to call it a clinically important traumatic brain injury? Not the not the points that they look at for you to say PCARN positive or PCARN negative.
So I'm looking at it too. So I think it's like death from a TBI, if they need a neurosurgery intervention, intubation for more than 24 hours, hospital admission for more than 2 nights. And then
Yeah,
obviously
those are the
like
ones they look at.
and the CT findings that we think of, like intracranial hemorrhage, edema, those type of things.
Right, and those are good. Those are the ones that require right neurosurgical intervention. How many times do we admit a child right with a non-depressed skull fracture that is otherwise well, is admitted for 24 hours and then goes home? So in reality, if that patient was PCAR negative, does it really matter? Unless we're talking about non-accidental trauma, right? You can't use PCAR with non-accidental trauma. So if you're thinking that this patient is PCAR negative, did that CT really have an impact on what happened? No, right? The outcome would have been the same regardless. Hold on, give me 1 second. Let's open the door. Okay. And we look at PCARN greater than 2, less than 2, right? What is the one caveat with ages less than 2? What happens if you have a 1-month-old that comes in that fell out of the stroller or the bassinet, hit their head? What would you do with that patient? No significant symptoms.
I mean, you have to think about like the developmental stage of the child and how that sort of fits with the mechanism of injury, and just have a higher suspicion for non-accidental trauma in the cases of certain children younger than 2.
Yeah, for sure. I mean, always have that high suspicion of non-accidental trauma, not necessarily high suspicion, but make sure that that's not present, right? But the issue is a patient that is less than 3 months, right? They have a very thin skull, and it doesn't take much, right? They don't do much. They just aren't interact with the world. They may have some head control, and a 2.5-month-old will have some head control, a 1-month-old will not, right? They have a different cry. They still might be vigorous and well appearing, but your exam is not going to be the same as it would in a 6-month-old, right? So these are the type of patients that anyone over 3 months really had a low likelihood of clinically important traumatic brain injury on CT in general. But the less than 3 months, they fell into a different category. So even if they're PCARN negative, PCARN wasn't very validated with these less than 3-month-olds. So you need to have a high suspicion. These are the patients that you should have a lower threshold to CT and not just call them PCARN negative based on signs and symptoms. Do you guys have any questions on that? All right. So let's go through a case. Who wants to start the case? Who wants to go through it? And everyone can bring up some points along the way.
Wesley.
Sure. Case 1, 8-year-old male, previously healthy, found seizing in bed at home. No reports of previous headaches, fever, focal neural deficits. Physical exam finding? Question mark.
Yeah, I mean, on physical exam, patient is altered, not alert, and is not very responsive. So what are your top 3 differentials? And based on those differentials, what would you do? And you can do your top differential.
Can you say the physical exam findings again?
Physical exam findings, well, what do you want to know?
Vitals and current, just neuro exam. And
So
exam too.
vitals, afebrile, heart rate is 125, blood pressure is 100 over 60, and saturations are 98%. And neuro exam, patient is just lying there, will sort of wake up to respond to questions, but then goes right back to sleep. And you can't really do a full neuro exam on that patient.
Okay. Do we have a finger stick on this patient? Because top of the differentials are true seizures. still seizing probably, hypoglycemia or intoxication,
Okay,
from like a
so
medication.
finger stick is 90.
90.
Mhm. You want to do a UTOC? It's not going to be for another 2 hours, and you're gonna
Um,
have to, you might have to put a bag on the patient or cat the patient. So you're not gonna.
TBI is also high on my differential too.
Okay.
Um,
So what's some of the workup you want to do?
CT head,
With
labs like
contrast or without?
without contrast for now. And
Okay.
get like a CBC comprehensive just to check for electrolytes like severe hyponatremia, other things like that,
Mhm.
hyperkalemia. You can look for AST/ALT, just kind of like maybe look for liver injury that could be a sign for toxic ingestion for that.
Okay, good.
INR as well. Do we know any any family history at all?
No family history at all.
Okay. They don't
Healthy
take any
child.
medications?
Nope. They don't
Okay.
have any medications at home other than the usual Tylenol or Motrin.
Could we get a like tox labs as well, just in case?
Sure.
Um,
Also, you want to describe the seizures?
General tonic-clonic. GTC lasting a few minutes. When the patient arrived to the ER, he was no longer seizing.
uh, he's no
So
longer seizing, you said?
no longer seizing.
Okay. Could we also get an EKG?
We can. The EKG is sinus tach with no evidence of, Brugada, long QT, widened QRS. Now a trauma code is called overhead, right? So the CT is going to be occupied. What would you do? How high of a suspicion do you have for a clinically important traumatic brain injury? And in this scenario, what is something that you would want to do? Right, because we see it all the time in county. All right, trauma codes are called. We want a CAT scan, and we have to wait. Sometimes it's okay to wait. Sometimes it may not be okay to wait.
Uh,
Anyone else want to help? Jasmine, what would you do?
Sorry, for this kid with the generalized tonic-clonic seizure, that means that it's like the fact that it's not focal, that means it's kind of, there's no one area of the brain that's kind of hyper responsive. And then when did I need a little bit more of a history. I think I didn't get a good history on this kid. When did he stop seizing and how long has he been post-ictal? Because that makes a difference. I don't think my
Okay.
labs or my EKG, I don't think any of those things is really going to make a difference in an 8-year-old, right? Because you're not really worried about like formula being diluted. Those are like more concerning factors for when kids are younger and seizing, more so when they're 8. So I guess I need to know when he stopped seizing and how long he's been post-ictal, because he really shouldn't be post-ictal for hours, right? But the
Yeah.
fact that it was a GTC makes me feel better.
Yeah. And that's what mom was saying, that she thinks he was shaking all over, but can't really tell. Didn't pay attention to what his eyes were doing. But she said maybe 5-10 minutes, but he's been altered since the seizure.
And the seizure was in the morning and now it's the afternoon and he's in the ER? Or like how long was the seizure from when he presented?
He woke up mom saw him at 8:10 a.m. and now at 8:24 a.m. you're seeing him in the ER.
Okay, so that's really not that long for him to be post-ictal. So and there's no signs of trauma, there's no history of TBI, right? Like he didn't fall, hit his head, he didn't have a concussion or anything like
Mm-hmm.
earlier. Yeah. So he's 8. Likely he's gonna come to. He has a history of he has a GTC. It could just be a new onset seizure. So in the
Okay.
interim, to make myself feel better, if he's still post-ictal, I'd probably consult neurology.
Okay.
Not that it would really, not that it would really do very much. So it would probably schedule him to wake up and then get an outpatient EEG and an
All right. So,
MRI. But I don't think I
so
need to
you-
rush to a CT scan.
okay. Well, see, I mean, the first floor CT is not available. You wait a half hour, you start seizing again.
Okay, that's different now. That's a second seizure in 24 hours. In a kid
Okay.
that's never seized.
Now what?
So,
CT is open.
okay. So yeah, I mean, still waiting on my neuro consult. I would get brain imaging at this point. Did anything?
Okay.
Did any of my labs come back? And obviously stop the
No.
seizures.
Okay.
So I give medication.
All right. So
to
you get
stop
your
the seizures.
CT scan. My mouse. That's the CT scan. What do you do now? Our
Hold
current
on.
institution. You do.
Who else wants to comment?
Anyone?
He had a GTC with that, and not a partial
What
focal.
mom says. That's what mom says.
So transfer.
Tobias transfer.
Oh, I see.
I think neurosurgeon wants to comment.
Neurosurgery. The neurosurgery PA comes down and says he's too young. We have to transfer.
Yeah, I think neurosurgery would just poop themselves at the 8-year-old.
100%. So
Yeah, Tobias, you're right.
now 100%, right? The seizing, if the seizing is controlled, right, they're still altered. You see this on brain imaging, and you plan to transfer. What would you do for the transfer of this child?
Yeah, I think Tobias said it in the chat. He said call my mo and then intubate, sedate, and transfer. So I think, yeah,
Exactly.
I think what you're worried about is protecting the airway, right? So
Exactly, right. This is a type of patient you don't want to put on a bus and without a protected airway, and then it's too late, right? So in a patient like this, they're seizing, you're going to stop the seizure. If they have a second seizure shortly after, no history of seizures, afebrile, still altered, or in and out of consciousness, right? Have a low threshold to CT a patient like this. And if you do see anything like this, intubate, sedate, transfer. Right? So this is just a spontaneous, non-traumatic hemorrhage, right? It could present differently depending on the age, right? In infants, poor feeding, vomiting, irritability, bulging fontanelle, be wary of this, right? And altered mental status, especially if the parents are saying, my child is not acting appropriate, right? And a child, headache, vomiting, visual changes, any focal neuro findings, right? Seizures in a patient that does not have seizures, is afebrile, right? Is lethargic, is in and out of consciousness. And then obviously if they have Cushing's triad, right? And this is one that's scary. So ruptured, now AVMs, it's themselves are not going to give you necessarily any symptoms. It's when these rupture that's you're gonna see a child that may be altered, seizing, or any focal neurological deficits depending on where they are, right? So they're vascular abnormalities. Nearly all are thought to be congenital. Most commonly, they're supratentorial, right? And they can present with headache, neurologic deficits. If it's a small vessel, they can just present with a headache, right? If it's a large vessel, then you can see more severe symptoms. Right? The size of the AVM does not predict any future hemorrhage. So if you get an MRI and incidentally you find an AVM, it does not mean that it will rupture, right? If it has ruptured, then this is something you would find on CT, right? MRI with and without angiography is going to be good to find unruptured AVMs. Of course, you're not going to MRI every single patient to see if they have an AVM or not, which makes it worrisome, right? You just don't know who's living with an AVM. Now, these need immediate neurosurgical intervention, right? Will they need surgical resection? Will they need coiling? And what most importantly, and not just here or wherever you guys go, is to know the capabilities of your hospital. Know the surrounding institutions that can handle these, so you're not scrambling last minute to try to find hospitals to go to. Mortality is 10%, and if they're in the basal ganglia thalamus, the mortality rate is much higher. Increased ICP, right? You can consider atropine in less than 1-year-olds. Usually, if I'm intubating less than a 1-year-old, I do give them atropine just to blunt that vagal response. Lidocaine, I don't really think we do anymore, right? Avoid propofol if they're hypotensive. In the meantime, elevate the head, maintain C-spine, right? You don't want to hypoventilate them. You don't want to hyperventilate them too much, right? Have them sedated, give them some hypertonic, whatever's faster. If mannitol is in the crash cart, give mannitol. If hypertonic is more readily available, give hypertonic. All right. Who wants to read the second case?
Drenis, can I just ask a question? For the last case, like we typically will sedate, especially like patients with seizures, like adult patients with propofol. What would you guys recommend you use for sedation for this kid then?
So for seizures, isolated seizures, then I also use propofol because it's a good antiepileptic. But if you have someone like this who has obviously, or anyone that has blood pressure discrepancies and they're hypotensive, you don't want to use propofol. And someone like this that you want to maintain their cerebral perfusion pressure, you don't want to drop their pressure. In fellowship, anyone that came in like an ESI 1, ESI 2, that we didn't know exactly what was going on and needed to be intubated, we typically use etomidate. Unless they're septic.
Like their drip then going forward.
You can do a Versed drip.
Okay.
You don't necessarily have to do, propofol. Obviously, if you intubate, you start a drip, right, and you get a CAT scan and their CAT scan is negative, then propofol is fine. But hopefully you give that sedative, that paralytic, and you get the CAT scan in time. The paralytic's going to last 30 minutes. So hopefully you're able to see something like this even when in the CAT scan, right? One of us is going to go into the CT area with this patient and no one's going to miss a finding like that. All right. Let's go to the second case. Who wants to read the second case?
Four-year-old male presents to the ED with wobbly gait. Parents admit persistence of symptoms for 1 month, but worsening over the past few days, with random episodes of emesis worse in the morning. And on physical exam, you have normal vitals, extraocular movement intact, normal motor and sensory exam, and a wide base gait with difficulty turning corners.
All right, who wants to go through some differentials?
Well, with random episodes of emesis worse in the morning and neurological symptoms, I would definitely be concerned for some sort of space-occupying lesion in the brain, possibly causing hydrocephalus, especially with the wide base gait. So there's a pretty, broad differential for that. It could also just be hydrocephalus without a mass. But those are the things that immediately come to mind when I'm thinking about worst cases.
Excellent. So, this is I couldn't find this patient, but it's an MRI, right? So you do see dilated ventricles, right? And anything else that pops out?
In pituitary area, irregular.
What'd you say?
the pituitary area by the base.
Right where? Right here?
Yeah.
Right. So you have a mass that's causing hydrocephalus, right? So you have obstructive and non-obstructive, right? Communicating, not communicating. Obstructive is usually the stenosis of the cerebral aqueduct. Congenital tumor, it could be after a hemorrhage or infection. You have, from a posterior fossa tumor, malformations. And then non-obstructive, it can be from scarring following a intraventricular hemorrhage, meningitis. Could it be something congenital? Could it be post-traumatic? So, and this is something similar you're going to see in adults, right? Where there's a wet, wobbly, and wacky, right? With hydrocephalus. So, in infants, macrocephaly. Now, remember, hydrocephalus will likely cause macrocephaly, but macrocephaly does not mean a patient necessarily has hydrocephalus, right? So then you have sunsetting, which is that downward eye deviation, lid retraction. In older children, you can have visual field deficits, double vision. And diagnosis, the first test you're gonna do, obviously in the ER, is gonna be a CAT scan, right? But MRI is the optimal test. And the same as the others, right? Treatment is you can have airway, cardiac monitoring, neurosurgical consultation. And for our purposes, we're going to try to stabilize and transfer these patients out. MRI brain, if we can get it, is ideal. Pre-op labs, I mean, we can do all of these, especially if a patient is going to stay within H&H.
Also,
So it doesn't
I have a
delay.
question. You will
Yeah.
like do an MRI without a CAT scan. I think that if it's like daytime, you will like I don't know if I will skip the CT scan maybe, but I don't know if that is something that
The problem with just
Ideally,
getting an
that is
MRI,
best.
yeah.
It
Okay.
might be difficult for a 4-year-old because
You have to
they might
separate
need to
the
be
group, yeah.
sedated.
Yeah. Okay.
But ideally, that's the test of choice. Now,
Okay.
if all stars aligned and anesthesia is available, or the patient is very cooperative, or on
Okay.
the
Yeah.
worst case is altered and just sitting still, can you get an MRI? Yes, right. But unfortunately, we've seen that the stars don't always align the right way.
Okay.
I think, Jeff, the most recent kid you were able to get an MRI on, right? Which
Yeah.
is impressive.
Yeah, it happened pretty quickly, but it usually has to be daytime when they're already there. It's worth calling the PICU because sometimes there's an extra guy. It's worth making the phone call, but it's going to be obvious quickly whether it's going to happen or not.
Mm-hmm. Yeah. Yeah, and that's for help. I mean, if PICU is in-house and the attending is available, right, they can help. Maybe they can even go upstairs with the patient if they're able to. Hopefully, I don't know if we do it, but these rapid MRIs that can be done in 3 to 5 minutes are ideal, instead of having a patient in the MRI suite for 40 minutes. So, I mean, this is more obvious. Hydrocephalus here on the left of your screen, no hydrocephalus on the right of the screen. We see this often, kids with shunts. So we have to be aware of them malfunctioning, what signs are acute, what signs are subacute or chronic. Right? Some of the acute findings are nausea, vomiting, irritability, seizures, headache, and when you go further down the list, it's getting more severe. Subacute or chronic, are they slowly changing their behavior, right? Is their feeding patterns changing? School performance, attention span, daily headaches, or they didn't have headaches before and now slowly they're starting to get headaches. Increase in head size. You should all have a heightened awareness of, is this shunt malfunctioning? We do both of them, right? We do a shunt series, which is basically a set of X-rays to look for any kinking and to see if the shunt is in the appropriate place. And as I mentioned before, right, these rapid MRIs, they call them, is ideal. They're not much longer than a CAT scan, and it saves these patients radiation because you can imagine how many times they present with similar symptoms and they get CAT scans. If there's radiographic changes in asymptomatic patients with changes in physical exam, it's like a mouthful, right? You need an urgent consult. However, if you have radiographic changes and the patient is symptomatic, this patient needs an emergent neurosurgery consult. If the shunt has malfunctioned, right, and macrocephaly or they have hydrocephalus, I think any neurosurgeon is able to tap that shunt and relieve the pressure. So that might be something that can be done emergently to stabilize the patient and then be transferred out for more definitive care. All right. Case 3.
I think with shunts, because we don't really see them very often here, but it's important to remember that most shunts need to be replaced, right? So just because you have a shunt that's placed when you're 2 years old doesn't mean it's going to last you for the rest of your life. 50% of them fail within like 6 to 8 years. So like a lot of these patients that you'll see will be will be premature, right? So they'll be like 25, 26, 27 weekers that have had hydrocephalus and that may need like shunt replacements. And usually within the first 2 years of placing the shunt, the majority of them will fail. So if you see like a young kid, a young child that's coming in and they're vomiting or mom's just saying that they're irritable, the symptoms are really non-specific, think of a shunt malfunction. And then also when you have like these older kids that come in that are developmentally delayed, maybe have autism, maybe are nonverbal, if they're coming in with irritability, vomiting, don't just kind of write that off. Like always think of the shunt being that could be malfunctioning. And just remember, keep in mind, like always ask about the shunt history, right? Just because you have a shunt doesn't mean it's going to last for the rest of your life. And if you know that the shunt was replaced maybe like 6-7 years ago, it's probably time for a revision and it's likely malfunctioning. A shunt series and a CT scan is easy enough to do, but just always keep in mind a lot of these kids are nonverbal that have shunts placed, and so they can't exactly tell you, like, I have a headache, I'm not feeling well, I'm vomiting. A lot of these symptoms are really non-specific. So just like always, get a history of when the shunt was placed and a good history of what's actually happening with the kid.
And shunt infections are most common the first 6 months after being placed. So if you have a patient that comes in 1 year after the shunt and is febrile, just know that the likelihood of infection is low. Now, if they come in 3 months, doesn't matter if they have URI symptoms, that is something that needs to be investigated. All right, cool. Who wants to read the next case?
Previously healthy 9-year-old boy is walking down the hallway at school when he feels like he can't take the next step. He falls down. He's brought by ambulance to the hospital. On physical exam, he has a blood pressure of 150/90. He seems unable to follow commands. He has a mild right facial droop, and he has a 5 out of 5 strength on the left upper extremity and left lower extremity, but 3 out of 5 strength in the right upper extremity, right lower extremity. So differential on this, considering the blood pressure, considering altered mental status and right-sided deficits, I'd be concerned about like some sort of focal neurological process, either again an AVM, but lateralized, or even ischemic with that blood pressure being so high for a kid.
Right. So you see how you're right on the money, Nick, but you're hesitant to say what the last thing you said instead of being the first. If this was a 39-year-old, what would be your first thought?
Stroke, call a stroke code. But
Exactly. Right. And we don't see this often. It is not a common thing in pediatrics, but I gave you these physical exam findings. And if this patient was 30 years older, you would not hesitate to think about a stroke, right? Now, we don't always think about it, but we don't want to miss it. Especially if there's focal deficits, right? This patient has right-sided deficits.
I don't know, in my mind, a 30-year-old and a 9-year-old are kind of the same patient. They're both very unlikely to have it, but they have real findings, so I would treat it real. I would probably do a sickle prep as well, but you know, a 30-year-old is very unlikely to have a stroke, the same as a 9-year-old.
Yeah.
The sickle prep is an important point that that was just made, because even though New York State, we have our own newborn screening for sickle cell, we have so many migrants and immigrants coming in now. You always want to make sure that we're not missing something.
Right. All right. So you get a CAT scan. Anything that pops out. And this is subtle.
Hypodensity in the left, maybe insular cortex, kind of impinging on the lateral ventral.
Right here?
Yeah.
Good. So it shows a left basal ganglia infarct, right? Very subtle. And then if you were to get an MRI, this is what you would see. So strokes, they're rare, very rare in children, right? You either have ischemic or hemorrhagic. And like Mark brought up a good point, right? Sickle cell disease, you have 6 to 9% incidence. Cardiac disease, right? Some metabolic conditions, coagulopathies, any neurocutaneous syndrome. That's why in these patients that come in with stroke-like symptoms, undress them. Do they have any cutaneous stigmata that might aid you into, you know what, this patient has these findings, right? A lot of hypopigmented patches or hyperpigmented patches, a high likelihood that there's something in the brain. Do they have any structural disease, right? Or moya, for example. Now, it's a shitty situation to be in, right? Because there's no treatment like we have in adults, right? An adult that comes in with an ischemic stroke, you're going to give TPA, right? Please correct me if I'm wrong. But there's no consensus on treatment for acute strokes in kids. The main thing to do is, right, to stabilize and prevent any secondary neuro injury. You don't want that ischemia to turn into hemorrhagic, right? So you want to maintain normal tension, normothermia, euglycemia, avoid hypoxia, and try to maintain cerebral perfusion pressure as best you can. You can initiate anticoagulation therapy, right? You want to aspirin, unfractioned heparin, Lovenox. But again, TPA has not been studied in children. It's not FDA approved. So that is something we just don't do. And then if it's a hemorrhagic stroke, different story, right? You got to get neurosurgery involved. Now, this is a big one also. And we've seen a few of them over the past, I want to say 1 year. I've seen a handful since I started. Sinus venous thrombosis, right? Can present with no symptoms, mild symptoms, or severe symptoms. Clinical history, dehydration, right? Mastoiditis, inflammatory conditions such as lupus, right? Lupus can present. You can't go wrong given diagnosis of lupus for anything. A hypercoagulable state. One of the big ones that we also see is sinusitis, right? Especially in the teenage population, if they have severe frontal sinusitis, it can seed into the brain, cause like a sinus thrombosis. Those patients, again, ABCs, you're gonna consider anticoagulation, and if they have any underlying infection, you need to treat that infection, right?
Will you do a CTA on these patients? Because I will, if that kid
Yes.
was my patient initially, I would just do a CTA also.
Yeah, it's actually probably a good thing to do a CT, CTA, or a CTV on the initial testing if you have a high suspicion for something like this.
Okay.
Because a non-con CT alone might not point this out.
I mean, he has like a pretty significant physical exam finding that can be like a large vessel occlusion also. So
Correct.
yeah, all right. Just wondering.
Oh, excellent point. Yeah, no, excellent point. All right. Next case. Who wants to read this one?
Hello.
All right, I'll read it. 11-year-old male noted his arms were heavy when he boarded the bus for school. On arrival, he collapsed on trying to stand and was unable to walk. He's had 2 episodes of urinary incontinence, no fevers or sick contacts, and on physical exam, mental status and cranial nerve exam is intact. Motor, for the most part, is normal bulk, but there's spasticity in the legs greater than the arms, left side greater than the right. There's decreased rectal tone. Strength is 2 out of 5 in the left upper and left lower, 3 out of 5 in the right upper, and a 3 out of 5 in the right lower. Sensory is decreased from C5 down, and the reflexes are 4+ at the left ankle, 3+ elsewhere. What are some of the differentials, and what would you do?
Max.
Would be concerned for cord compression from either trauma, like, maybe non-accidental prior, a mass. It's all very acute, so I wouldn't be thinking as much about chronic processes. I would probably try to get this kid a emergent MRI, and maybe consider steroids, and transfer for neurosurgery, depending on the results.
Excellent. Great job, Max. So, right, sensory level, motor level, and decreased rectal tone indicate some kind of spinal pathology, right? The imaging of choice is going to be a stat MRI spine, right? And again, these are the type of patients that at least someone should accompany in the MRI suite. Anything you see here? What'd you say?
Like, is there some sort of collection down in the top of the thoracic spine?
It's right here.
Oh, okay.
So, acute myelopathy, right? Transverse myelitis, and a few other that I'll speak about too, and as a spinal pathology, right? Can you get it from trauma, right? Is there an infection? Is there a tumor? Is there a hemorrhage? Any demyelinating processes? Or is it anatomic, like you mentioned, right? Is it a tethered cord, right? It could be infectious, could be usually febrile, especially with like a discitis, spinal epidural abscess, right? Those are all possible. Now, transverse myelitis, right? It's rare, but it's an inflammatory condition, demyelinating, right, in the spinothalamic tracts. Most commonly, it's post-infectious, or it could be idiopathic, right? Some of these that EBV, CMV, measles, mumps, we don't see anymore, but EBV we see kind of mycoplasma, lupus again, never wrong, right? And some of the diagnostic criteria: sensory motor, autonomic dysfunction, right? Clearly defined sensory level, no evidence of compression, cord lesion. And if you tab, you get, CSF pleocytosis, elevated IgG. Now, what differentiates transverse myelitis with Guillain-Barré on a physical exam? What's the big one? For the sake of time, I'll just tell you. Right, in Guillain-Barré, you have areflexia, but preserved sensation. But in transverse myelitis, you'll have preserved reflexes, but a decrease in sensory. So that's one differentiation between transverse myelitis and Guillain-Barré. Right, in the ED, we're going to CT or MRI before LP, right? Get some CSF studies. Then high dose steroids, right? If there's motor impairment, you want to do a plasma exchange. And obviously, we're not going to do these on our own, right? We're going to consult neurology, neurosurgery, and follow what their recommendations are. Now, what is this finding here that they're showing us? Right, these are epidural findings. Now, it could be an abscess or it could be a hematoma. And you guys know this better than I do, but correct me if I'm wrong. The last conference I went to, they said that a spinal epidural abscess was the most common missed diagnosis in the first ED visit. And I mean, I'm not surprised, right? It's a difficult diagnosis. We're not MRIing everybody. We're not CTing everyone's spine, right? The back pain typically precedes other symptoms, right? You get fever, headache, vomiting. If you have compression, you'll get those compression symptoms. You can get bony tenderness, right? And then the treatment is you need to decompress. You need to start antibiotics and very big guns, right? You're going to need anti-staph, Vanc Ceftrax are going to be the big ones. Hematoma, right? You can also see these. You can also see spinal AVMs, right? Is there a trauma? Is there a hemorrhagic tumor? And again, MRI of the spine is the test of choice. And the same with an abscess, right? You want to decompress to improve the outcomes. If you do get an MRI with these symptoms and there's no finding, right, then we're going to do an LP. You want to send for viral studies, right? You want to look for, is there anything like MS? Is there ADEM? You look for Guillain-Barré, and then basic rheumatology labs. I think we're out of time.
Yeah, I think we're out of time, but that was great.
All right. Does anyone have any questions in a minute or two we have left?
Thank you.
In conclusion, right, a good history and pattern of symptoms aid the diagnosis, right? Good neuro exam, especially with kids, don't just barge in there and start examining them. You want to set yourself up for success, right? And obviously recognition and treatment in the ER may improve outcomes, and know what we have and know what we don't have. So capabilities of the institution are key, not just here, anywhere. All right. Thank you, guys.